Hi everyone, my name is Nav Cavale. I am a London plastic surgeon. I'm also the chair of BFIRST, British Foundation for International Reconstructive Surgery and Training. I'm really pleased to introduce Mr. Stuart Watson for another time, actually, giving us another one of his amazing webinars. Mr. Watson is a retired consultant from Cannesburn, does charity work in Ghana and Malawi. Hopefully we'll be getting more and more involved with BFIRST sort of running as well. And actually more recently gave an amazing Gillies lecture at the BAPRAS meeting that we just had in Newcastle. And we'll also be talking on our next BFIRST Overseas Day, which I'm really keen to get all of you to come to, which will be in Leeds, Wednesday, April 24th. I think I've got that date right. Do come. It's jointly with the BSSH, so the Hand Society. So for those of you who are interested in hand surgery, be it plastics or other routes, please do come along. And for those of you who are interested in overseas work, yeah, definitely please come along. And yeah, it gives me great pleasure to hand over to Mr. Watson, who's going to be talking to us about local flap reconstruction and how to design. I mean, I think local flaps are probably one of my favorite bits of plastic surgery. I think it's way cleverer than some of the fancy microsurgery that we do, that the thinking that you have to do and the planning, you've got to be really, really good at it. So I'm really looking forward to this. So thank you. Over to you.
Thanks, Naveen. I'm very grateful to BFIRST for the opportunity to speak again. There's going to be a follow-up to this talk also about flaps in a month's time. Welcome to everyone from all over the world who's joining. It's a great privilege for me that you have given up your time to listen to me. I'm just going to share my screen and start this presentation. I shall start slightly slowly, just to make sure that as many people as possible who are joining at the start time of 1 o'clock can join. As far as possible, if you put questions on the Q&A section of it, then we can deal with the questions somewhat as we go along. And the last one that I did, that worked really well. So we will look out for questions on the Q&A, but anyway, welcome everyone. So this is a somewhat basic talk about the principles of flap design and technical tips. But I hope you'll forgive me, it's not comprehensive, but it's also a distillation of some of the things that I have thought have been important about planning flaps from my career of doing reconstructive surgery. I recently retired from the Cannesburn unit in Glasgow. And it's mainly focused on hand surgery, but the point is more about the principles that the different cases show. So starting off, this is all about flaps. And I can understand people watching may think there'll be many defects where you can treat this injury, like a fingertip injury, conservatively, or you can treat something with a graft. But the point of this is that we assume that any of the defects that I show in the diagrams in this talk are ones that we feel really need a flap, and they need a piece of vascularized tissue. And what I'm going to talk about is using the basic principles of design for small defects, and then a little bit, and I'm going to emphasize that, and also emphasize some of the minor but important technical issues which surround that you don't always see here in the textbooks. And that's essentially what I'm trying to do with this talk. And I hope that works for some of you, at least, in listening to this. I'm also going to talk about using larger local flaps based on known vessels, and a small amount about using large flaps from elsewhere in the body. So that is essentially how we choose how to use flaps. We either use the basic principle of a design, and that tends to be for small defects, not always for small defects. And then when things get more difficult, we use larger local flaps based on known vessels. And then when they're really difficult and there's no options of those first two, we use large flaps from elsewhere in the body. And that's essentially the reconstructive ladder of flaps. So starting with using basic principles designed for small defects. I'm thinking of basic principles. I always think about a transposition flap as the fundamental principle. And this is an example of something that I used to do and I was trained to do for defects after Dupuytren surgery. So this is an example. The red on the finger is the defect. And this would be in a really difficult Dupuytren's case where you had to do surgery on the PIP joint and correct a very difficult Dupuytren's contracture, not for a standard Dupuytren's this at all. But one thing I was taught was doing a lateral finger transposition flap, which is an incredibly simple flap, which is taken from the same finger. And the basic principle that we're thinking about in terms of planning this flap is it has to be wide enough to cover the defect. And this distance here has to reach the end of the defect when the flap is mobilized. And that's the fundamental things that you think about when you're planning this flap. And one thing that I'll come back to during this talk is, if in doubt, you make it a little too wide here. And if in doubt, you make it a little bit too long like that. Because once you've committed yourself to drawing the flap, you can't change that. And there are various factors that I think are really important to think about when you're doing flaps that mean that what you see, what your eye tells you about how long a flap needs to be, isn't necessarily what actually happens in reality. And I'll talk a bit more about that. But this was a flap that I did for many years, but in the latter part of my career, I ended up hardly doing at all. And so that's another thing about flaps. And sorry, this is just to go back. This is actually shows why the flap works so well, because when you do a Dupuytren's, you preserve the digital artery, and you're mainly working on the digital artery from the volar side, palmar side, but you preserve these dorsal branches that go into this flap. This one in particular, this is the arterial anatomy of the finger, and there's a perforator which goes to the dorsal skin, the lateral skin, going dorsal from the digital artery, and that is going into this flap. And all the flap does is sort of slides around the finger, and it minimally stresses this perforator when it slides around, because it's actually making that perforator looser when it moves around. But laterally in my career, I hardly ever used that flap, because if you really need a flap for Dupuytren's, a simpler thing to do is just move the digital bundles closer together and put a skin graft on, or you can even just use the bridging phenomenon. So that's an example of a flap that illustrates some of the principles of flap designs, but actually I used for a while in my career, but I didn't use so much towards the end because it wasn't really necessary. So on the dorsum of the hand, I'd like to sort of talk a lot about this as an example of the way that we design flaps. And the dorsum of the hand is interesting because it has a bit of loose skin, and there's some capacity for designing local flaps without skin grafts, but mainly there is not much loose skin on the dorsum of the hand. And you can't, for example, use that palmar flap to cover things on the dorsum of the hand, this lateral flap, because if you move this laterally to cover a defect, it stretches the perforators that supply it unduly. And also you have this watershed between palmar and dorsal skin here, and it just doesn't work at all well. So you probably can grasp that principle from the textbooks that there's hardly any flaps that are described taken from the lateral side of the finger or the palmar side of the finger, which is obviously precious as well for covering the dorsum. So, however, you commonly see relatively small post-traumatic defects on the dorsum of the hand. And I'm sorry, I don't have photographs of all these cases. I actually cut back a lot on photographing about 15 years ago because it was difficult to do in our department and we weren't allowed to take photographs ourselves. So I've got some diagrams which I've done of flaps that I've improvised for various situations. So here's the first one. A smallish defect on the dorsum of the PIP joint that definitely needs a flap. So a way of designing a transposition flap like this is to make it oblique across the digit in that manner. And the fundamental principle of this is that vessels come into the base of the flap. So a thing to really, for the people who are more junior in their careers, to sort of latch onto from this talk and to take away from it is that wherever you're designing local flaps, if you have a perforator going into the base of the flap like that, that flap will tend to do well. And that is a recurring theme around the whole body. So this is a way that on occasion I would have repaired a defect like that. And it always needs a full thickness skin graft for the secondary defect. But it gets it closed very nicely. So in practice, this is how I would draw that flap. And the point of showing you this drawing is actually taking it to near the mid-lateral line on the dorsum there and making the flap that shape so that it is as big as it can possibly be, because it doesn't really make any difference whether you have a skin graft which is that size or a skin graft which is that size. And in fact, it actually looks better to the patient afterwards if you have a skin graft which reaches the mid-lateral lines. And also on the palmar side of the finger, it's better from a contracture point of view. So when you design a flap like this, you make it go to the mid-lateral line like that. And that actually then gives you a pointed flap which fits into the shape of the defect like that anyway. And that fits well. So the key things to think about when you're planning this is this length has to reach under absolute circumstances, and I'll talk further about that, to the end of the defect. And this is something that I've never seen this flap in any book, but I've used it many times, this oblique design on the dorsum of the fingers. And the reason it works is because of those vessels that go into the base of the flap like that. And the key thing, if you ever raise a flap like this, is that you don't cut beyond the Cleland's ligaments here in raising the flap at the base of the flap. And when you work towards those, you're careful because the perforator is coming through at Cleland's ligaments on the side of the finger and the tiny veins that help drain it. And you need to, if you go beyond that, you will almost certainly cut that vessel. And it's also better if you can to do it under magnification, but you can see it's still a very, very simple flap. Other things about designing this flap, and this applies all over the body, and I realized that this after much, much experience, is there's a tendency to feel that you have to design a transposition flap as a sort of rectangle shape like that with straight sides. But actually, if you need more width to the flap, you can make it shaped like this. You can make it more elliptical shaped, not to a crazy degree, but to a modest degree. And this works, again, at its best when there is a perforator in the base of the flap. If you simply design random flaps like that, then it becomes more and more risky. But if you have a perforator in the base of the flap and you need to cover a wider defect, then you can make it more elliptical shaped. And only experience and judgment and the individual case can tell you what that is. And if under magnification, you can see the perforator vessels going into the base of the flap, you can then make little back cuts at the base there that make the flap more flexible. as well. So you're actually working towards turning it into an islanded ad hoc perforator flap, if you can see the vessels in the base. But many times in these small flaps in the hand, you can't do that. But there are occasions when I've been able to do that. And the advantage of that is, for those of you that are experienced, you'll know that you're going to get an awful dog ear here when you transpose this flap. So if you can actually see the tiny vessel that comes in the base of the flap, you can actually trim that dog ear a little bit at the time with care. But one thing to bear in mind is that some of the venous drainage of the flap will be going this way through the veins. So you don't want to excessively trim a dog ear and damage the veins. Other really important things to think about when you're raising these flaps, and this is particularly so in the hand, but it also occurs in many other parts of the body. For example, in the distal half of the leg, where you have the Achilles tendon and various other tendons. Where do you have to be careful raising this flap? So the two places to be careful are over the extensor paratenon, and you must preserve the extensor paratenon to get good take of your skin graft. So you can be quick in some places and not worry too much about it, but over the extensor paratenon, you want to be careful raising this flap. So that's another thing I always think about when I'm raising a local flap is what is there underneath that I might expose for the skin graft that's important. And the obvious place that you need to be careful dissecting is where you come near the perforating vessels there. So that's just an example of a really basic flap that consistently works well, that's not very elegant, because you often have a dog ear here when you raise it, and it needs a skin graft for the secondary defect, but it works. And I've tried to show there some of the principles of raising it. So again, the reason that it works is that you have these dorsal vessels which are coming in to supply the skin of the dorsum of the finger. And they're particularly abundant at the DIP joint. So moving on, we've shown a flap here for coverage of the PIP joint. For the DIP joint, it's more difficult because there's no kind of proximally based flap. So we now know from huge experience that distally based flaps, if they have a perforator in the base, work just as well as proximally based flaps. So just with a small amount of thinking and application of principles, you design a flap which is distally based and oblique like that. And you can see I've made a mistake here in doing this drawing, which I did for a talk about 10 years ago, which is this flap is too short. It doesn't need to be as short as that because I can take it to there, and it's also too narrow. So where you'd actually make this flap go if you were doing it properly is you do something like that, because you always want it to be absolutely certainly as long as it has to be, and you want it to be as wide as it has to be, and be sure about that. So there's the flap actually drawn as you might do it. And you can see how this is what I was trying to say about the designing a flap that is more like an ellipse. You can see how it's actually narrower here where the defect is sitting, and then it gets wider again there. And as long as you base it where there are perforating vessels there, then this flap will do well. And there are these known perforators at the DIP joint which supply this. So more so than the PIP joint, this oblique flap is one that has got me out of what I thought were tricky little silly situations consistently. And it is just based on some fundamental principles of decent transposition flap design and basing it on where a perforating vessel is. Something else that is really important that I'm not sure I'm going to put this into words as well as I should, but something to think about is there are lots and lots of structures on the body which are cylindrical or not flat. So when you design a flap, we look at this and we look at it in 2 dimensions. And you even do that when you just look at the dorsum of a finger straight on. But this distance is actually much further than your eye tells you it is, because it's going round a cylinder, as is this distance here. It's much further than you think it is. Also, your flap isn't a sheet of paper. It's something with an inherent thickness. So the length that the flap has to be long enough to accommodate the thickness of the flap when it goes round a cylindrical surface. So if you imagine the defect that we're looking at there initially, you look at the defect, which maybe was down to the extensor tendon or included the extensor tendon, which had to be repaired or reconstructed, and your eye tells you that the distance is to there. But actually, once you put this thickness of flap on it, the distance is that. So always accommodate the fact of the contour of the part of the body that you're working on to the length that of the flap has to be. So when you're making a measurement, and people use foam patterns, for example, for this reason, because the foam has a thickness that mimics the thickness of the flap. But when you're doing tricky local flaps, where you're at, where this is really important is where you're heading towards the limits of the blood supply of the flap. Always bear in mind that the thickness of your flap is really important in terms of whether the flap will fill the defect. And that is something that I think is hugely underrated. And a surgeon called Simon Knight, who was a great hand surgeon in Leeds, told me this when I was a junior trainee in Manchester about 35 years ago, maybe 40 years ago, I can't remember. He said, you know, when you're operating on a cylinder, you have 3 dimensions, and you have the thickness of the tissue that you're dealing with that significantly affects how your flap will go into defect. So I hope I've explained that well. But the bottom line is, when you're on a cylindrical extremity, take care of the flap, to plan the flap long enough. And the second thing about this is that you can see there that the blood vessels in the flap go around a curve, and the tissues that they're underneath are curved or even like a corner. And if you then put this under tension, it really, really stresses the blood vessels, because the blood vessels aren't just going straight, they're actually going, they're changing direction. And that's why flaps that go across features where there is a convex surface underneath, like this, the tip of the flap has a higher chance of dying, because the blood vessels are stressed by changing direction, and if it's too tight. So I've tried to explain there about how the contour of what you're operating on and the thickness of your flap does significantly influence how long the flap has to be. And that should be taken into account with the planning. And the other thing that hugely affects that is swelling, edema, because all the tissues will get edematous. So your flap will become thicker in the first 36, 48 hours. And then you can imagine that then becomes a vicious circle. If it becomes venous congested, it becomes thicker and thicker and thicker. And the times that I really hated in my career with doing local flaps is when you end up with a venous congested, swollen local flap that's like a bit of wood that you then can't actually put into your defect. So that's what you're trying to avoid. You're trying to avoid creating a vicious circle where your flap gets tight, it becomes ischemic, venous congested, it becomes more and more swollen, and that makes things worse. So moving on, talk now about shapes of defects. So other things to think about in terms of how you design a flap are the shape of the defect. So if you have a defect which is short proximo-distally and long from a lateral point of view, that lends itself superbly to rotation flaps. or rotation advancement flaps. And that's something that I think I never really appreciated at the start of my career. But in terms of flap design, rotation flaps work best where you have a defect which is shorter and wider. And transposition flaps you can fit to anything, but they have to be wide enough to cover the defect. But rotation flaps work best when you have a defect like this. Other crucial things to think about rotation flaps for the people who are less experienced is always step the rotation flap out like that at the start. Because when it rotates, this point shortens, so it goes into there. If you just draw it straight back off the defect, it is really, really vulnerable to failure. And if you have good perforators in the rotation flap and you know that they're going into that part of the flap there, then you can back cut it readily to get it to work. So here's a really nice case. I've got some slides from my colleague Jim Kirkpatrick, hand surgeon in Glasgow. And this is a really nice case, typical of his work, of a beautiful rotation flap for the dorsum of the thumb. So the principles to think about here after excision of this mucus cyst type lesion with affected skin for this patient. But things to think about from here is the whole point of the rotation flap is that you're taking the rotation flap where there is an area of skin excess, and that excess can be spared. So there's no skin excess up here on the thumb, but the whole point about rotation flaps is that you're trying to take the flap, you're leading this incision back, having stepped it out from the defect, you're leading it back in a smooth, wide curve to a place of skin excess. And that skin excess is sufficient. And the other thing you want to think about is you want there to be perforating vessels going into the base of it here that are likely to keep it alive if you need to back cut. And the point of the back cut is that if your flap sort of gets to a certain point and then it holds, and you can release it and allow it to swing further up by back cutting. And you can back cut safely if the vessels here are good. But if you're unsure, and you know from the anatomy that those vessels are going to be good, but if you're unsure, then you start worrying about how far you can back cut. So this is a hatchet flap, a rotation flap with a V to Y closure at the base. But you shouldn't ever hesitate to put in a full thickness skin graft or a split thickness skin graft into there for a rotation flap if it's necessary. And one thing I learned from my career is that in theory, rotation flaps should work beautifully on the scalp if you plan them to go back to the occiput, but they almost never close directly if they're for significant defects on the scalp. So, one thing that's in the books is the concept that you can plan a rotation flap on the scalp and you take it from an area on the posterior scalp where it's looser, but never hesitate to put a skin graft on. As Gillies said, don't compromise your primary defect for the sake of your secondary defect. Other things to think about in the hand, if you're thinking about doing rotation flaps like this, it's very good on the thumb because the thumb only has to flex about 40 degrees. But if you're going to do a rotation flap for a defect over the PIP joint of a finger, remember that this joint has to flex 90 degrees. And your donor site for your rotation advancement flap is over the loose skin, which has to flex through 90 degrees. And that's why that loose skin is there. So I'm less keen about using hatchet flaps for this unless I'm really sure that it's not going to impair the patient's flexion. So that's an example of thinking about how your donor defect, it may look good in terms of there being lots of loose skin there, but there is less loose skin on the dorsum of the hand than you think there is, because you have to be able to use this loose skin over the joints to flex your fingers. So here's a completely different orientation of defect. And this is one that I've seen probably at least 10 times in my career in dealing with hand emergencies, where you have patients with multiple narrow, abraded, nasty defects on the dorsum of the finger, and they're long and narrow. And you can see that's quite a challenge, because you can't readily do a rotation advancement flap won't work for that at all. There isn't a way of designing a transposition flap of this type for it. And what I've done many times for this defect is doing 2 bipedical flaps to close it. And it's not a perfect solution, because in these abraded injuries that are like this, the skin edges are a bit damaged and tatty. But these are often patients who've been in a road traffic accident, who've got multiple injuries, and you're trying to sort out this person's hand as part of a whole complex of things. And you're not wanting to do a distant flap, for example. You want to do something simple, and there may be multiple fingers which are injured, and you're trying to piece things back together. So an incision at the mid-lateral line on each side, and then undermining all of this bipedical flap. And then very carefully, you can see I've marked it. So there's a back cut there and a back cut there. So one thing about bipedical flaps is bipedical flaps always look very nice in theory, but when you try to move them, they don't move well, because if you don't make a back cut here, they just are stuck by adherence at that point there and at that point there. So the times I've tried to do bipedical flaps in the lower limb, for example, for a long, narrow defect in a patient who was on unfavorable circumstances, or seen other people trying to do them, they never move as well as you want them to move. So these are only for long, narrow defects. But in this particular situation, they work surprisingly well. So this isn't just a talk about hands, it's about the principle of thinking of, I've got a long, narrow defect here. The key problem here is that there's a lot of length to it, and it's caused a lot of damage to my different local flap options. But I can use the basic principle of 2 bipedical flaps. In my experience, if you've got this injury, you always need 2 to get this closed. Other things to think about are that if you do these flaps, which I've now drawn like this, you can make the back cuts, but preserve the veins that drain them. So that's another thing to think about. And the same thing applies in both bipedical flaps and fasciocutaneous flaps in the lower limb. And I don't know, probably some of the more experienced people who are listening will have had this experience where you're dealing with a challenging case. For whatever reason, you don't want to do a free flap or another distant flap in the lower limb, and the fasciocutaneous flap that you've got isn't perfect, but you can somehow find a way of making it reach the defects. And doing back cuts in skin or fascia whilst preserving the important vessels, particularly the draining veins, is an important principle when you're trying to get tricky, awkward things to work. So if I ever do this reconstruction for this problem, I always try and make sure I don't cut these veins that drain the flap. Because veins make a huge difference to flaps. Most flaps actually fail because of venous drainage rather than arterial input. And if you can preserve those veins whilst making these back cuts to allow the flaps to move. Another thing to think about, again, this is where the 3-dimensional principle of the cylinder actually helps in this case. You look at this, and these flaps look really narrow, don't they? But in cross-section, they're actually much bigger than they look. when you look at them like that. So they're actually quite decent size, these flaps. So even if you have to debride a tricky defect, you have a reasonable amount of tissue, but they're never big enough. And I think that in theory, you could turn this into a distally based transposition flap by making an incision like that and basing it on the vessels there, if it was really challenging. And that could well work, but it wouldn't work so well for covering the whole length of the defect. It's only going to cover this part of the defect. So the point of this part of the talk, showing the different shapes of defects, is try and get used to thinking about what is the shape of my defect and how do I actually use that to advantage in planning the reconstruction. And so these long, narrow defects are quite challenging because they damage a lot of the usual reconstructive options. And this is a simple solution to that situation. And there have been occasions when, with these bipedical flaps, I've even just left the defect at the side of the finger to heal because it's a relatively narrow defect. But usually I just put a split skin graft in, and you can probably understand from the principles of hand function, it doesn't matter if you have split skin grafts and slightly bad scars on the sides of the finger because it doesn't limit your function. It's only bad scarring is predominantly an issue on the palmar aspect. So just to go through some of the other classic options for dorsal defects, and this is to show some of the other principles that are available. So this is using cross finger flats for dorsal defects, and the most elegant way of doing this. And this is again a series from my colleague Jim Kirkpatrick in Glasgow. So this is a case where he'd done excising a nasty skin cancer from the dorsum of the finger for a gentleman, and he's got a clearly difficult defect there you can see to repair. And he's used an adipofascial cross finger flap from the adjacent finger. So what you do to do this is you raise the dorsal skin off at the subdermal level, preserving the subdermal plexus of vessels to the contralateral side away. And then you have this beautiful adipofascial tissue here. So you can see here how the subdermal plexus, very superficial of vessels, has been preserved in raising this. So this is quite a skilled technique, but it works really well. And then the adipofascial tissue is raised off the extensor parietinum. So this emphasizes what I was saying before about preserving the parietinum, because if you have any problems with the viability of this overlying skin, then it's better to have parietinum there. And the adipofascial tissue goes in place and covers the defect and then is covered with a skin graft. So this is a totally different principle which you can use in all parts of the body, using adipofascial tissue rather than skin as a mechanism for repairing defects. And for difficult dorsal defects of the hand, there are a number of papers from which I read about 30 years ago from the Far East, particularly about using dorsal adipofascial turnover flats from the same finger to cover defects. And I used those for a while, but they're quite tricky to do because the base of the flap is on the same finger. So you actually, if you think about it, you have the base of the flap like that. For the flap to be long enough, you then have to have the distance of the base of the flap and the length of the defect before it reaches. But this is a very, very good method of covering difficult dorsal defects when the adjacent finger is healthy. And this just shows the process of dividing it. So there's another principle for doing cross finger flats for the dorsal aspect. So what I've shown you there is taking the adipofascial tissue between the extensor tendon and the skin, and it's based on those perforating vessels that come off the digital artery there. But what you can do alternatively is you can deepithelialize a standard cross-finger flap and use, if you're unsure about using that method, just deepithelialize it and then turn a standard cross-finger flap. And there's another series of a standard cross-finger flap for dorsal defects. And that is a very robust way of doing it. But you then have to skin graft the defect rather than putting the existing skin back down. So there are two alternatives of use of cross-finger flaps for dorsal defects that work like that. Other principles to abide when you're doing cross-finger flaps is never violate over the joints for using the cross-finger flaps. And that's a general good rule for the dorsum of the hand generally, where you can avoid violating the loose skin over the joints for flaps. So finally, just for completeness and coverage of difficult defects of the dorsum of the hand, and partly to lead on to the next section of this talk, there is one technique that I've occasionally used over the years in terms of local flaps for coverage of tricky defects of the dorsum of the hand, which is this reverse digital artery island flap, which is primarily designed for defects of the fingertip, because it has the dorsal branch of the digital nerve and a branch of the radial nerve going into it that you can use to anastomose the digital nerves for really difficult fingertip defects. But on occasion, in really difficult cases, it's useful just to cover the dorsum of the PIP joint, if for some reason there is just no other local flap available. So this is a technically difficult, demanding flap where you have to carefully separate the digital artery from the digital nerve, and you have to be careful to preserve the branches of the digital artery, the perforators that supply this flap. But it is a very, very good flap if you're in a really difficult situation, and you can cover the dorsum of the PIP joint, the dorsum of the DIP joint, and the dorsum of the nail complex with it if you have to. But it's a tricky flap. And this is just showing the blood supply. That's where the flap is. And what you essentially do is you divide the digital artery proximally here. And this skin of the flap, which you can take down into the web, is supplied by this perforating branch. And you very carefully separate between the digital nerve and artery. But this is, you know, if you think of the transposition flaps that I showed on the dorsum of the finger as being grade 1 difficulty, this is about grade 5 difficulty for surgical experience. But it's a very, very nice flap. And I'll talk more about the principles of using flaps like that in this next section. So the next section is about using larger local flaps based on known vessels. And again, I'm going to use the hand as an example to talk about that. So far, essentially, I've talked about using fundamental principles of flap design where possible based on perforating vessels that you know are likely to be present from knowledge of vascular anatomy. But this is now using larger local flaps based on known named vessels. So difficult defect of large one on the dorsum of the index finger, classic flap for using to repair this is the Quaba flap. So it's a distally based dorsal hand flap based on the perforating branch of the deep metacarpal artery. So this comes out about 1 centimeter proximal to the line of the MCP joint, this perforator that Quaba described. And it's a classic island perforator flap where you totally island the flap. And because you have a good perforator with good draining veins going into it, which send branches down the dorsum of the hand to supply and drain this flap, it works consistently and reliably on the second and third web spaces of the dorsum of the hand. It is significantly less reliable, and Quaba described this in his original paper, I think, on the fourth web space. So this is a clinical example, and this is, I think, one of my cases. I'm not sure, it might be Jim's case, but it shows something really, really important, which is Gillies' fundamental principle of never compromise your primary defect for the sake of your secondary defect. So one of the elegant things about the Quaba flap is that there's some loose skin in the back of the hand, so you can close this defect together and it produces a nice, elegant outcome. But this flap was for a big defect, and when the flap was rotated, it was obvious that closing the defect would compromise the blood flow to the flap. And accordingly, because of that, we put in a skin graft to make sure that the flap works. So I hope everyone understands, that those that are less familiar understands how this flap has worked. There's a consistent perforating vessel coming in here, which sends vessels to supply this skin. This flap has had to rotate through 180 degrees, which challenges that perforator. So when you're raising the flap, you have to, if you imagine the flap in cross section like this, with the perforating vessels coming out the base of it like that, to make it rotate safely 180 degrees, you have to dissect out a length of these perforating vessels that is sufficient to allow it to twist through 180 degrees without these being kinked. So one of the important things about these type of perforating vessels is, don't make your dissection of them too short. You have to get some length on this so that it's not strangled by twisting. You can imagine if you have a short length on these perforators when you dissect them out, then turning it twisted. Also, if you have pressure from undue skin tightness on these perforating vessels, it'll kill the flap. So here's a very good, beautifully thought of by Alf Quaba, who originally described this flap, elegant flap, but also some lessons about ways to, maybe if I did this case, it was a little bit over ambitious for the particular problem to try and get it closed. So you never compromise your primary defect for the sake of your secondary defect. And if things look a bit doubtful, leave the wound open around where the perforator of a flap is, or put on a skin graft, so that you make sure you do everything to make sure it works. Just going to check, there's one question. Okay, so thank you. So anonymous attendee is asking about defects where you use muscle flaps which settle down over time, or fascicutaneous flap. That is a great question, and I think, to be truthful, I'm not going to talk about muscle flaps today, but I'm not advertising myself, but there's another talk in a month's time about choosing flaps, where I think I'll talk more about choosing muscle flaps or fascicutaneous flaps. But the person, anonymous attendee, who asked the question, would you consider muscle flaps over fascicutaneous flaps? It's a very, very good question, and it's not one with a simple answer, sorry. The principles that you've described there are important. Anthony has asked about the exact landmark and extent for the digital island flap. Yeah, absolutely. I'll just go back to that by going back my slides. Sorry, I need to move the Q&A thing out of the way. So when you're designing a distally reverse homodigital artery island flap, you don't want to make your skin paddle come too far to the dorsum, but you can basically take skin up to about there, and you can take skin down into the web, and you always, I feel, are best to take a small amount of palmar skin with it. So essentially, if you can imagine where it's safe to take the skin for the reverse digital artery island flap is that whole territory I've drawn there, and maybe a little bit onto the palmar aspect. But you don't want to go far across the palmar aspect, otherwise you'll cause a flexion contracture at that anterior border. There's a very nice paper from just last year. If you look up reverse digital artery island flap, the thrust of their paper was actually using a transposition flap to close this defect, but it gives a very good description of this flap from China, I think. So I'd suggest looking for that. Other things is that you plan the incision distally over the line of the digital nerve of the artery on the side of the finger, and you reflect the skin, and then you're very careful to dissect the artery out. And you explore in here, and you find, if you're innervating it, you find the dorsal branch of the radial nerve there, and the branch of the radial nerve and the dorsal branch of the digital nerve there. And you then cut those because they will give you sensation in this. I hope that helps. Mohammed Tariq, very good question. How to assess the flap for blood compromise during closure? I think if you're doubtful at all, if you see, I'll show you in the picture actually. You see how there are little tension lines there on the flap from it being a bit compromised, and the color of the skin of the flap is different from the color elsewhere on the hand. So I think comparing the flap with adjacent skin is really, really useful. And in this case, the fact that it's got a slight grayness to it is really, really useful. Fundamentally, if you're really doubtful, actually, if there's a little piece of the flap that you can trim that isn't going to damage closing the defect, that you can cut off to see if it bleeds, that's helpful. I hope that helps you. But if you're not happy with the color of the flap, give it a bit of time, see if things improve, like 5 minutes. If you see tension lines across it, like that different color there, then try and think of doing something different. And if it's not the same color as the surrounding skin, try and do something different. Also, you get an instinct after a while that if it's too tight or if it just doesn't look right. I'm sorry, that doesn't answer your question very well. I hope that helps. Okay, I'll stop the Q&A for the moment and carry on. So this is a Fouché flap. This is the next named vessel flap for the dorsum of the hand. And I just want to use this as an example of talking about other principles for flap design. So this is for a dorsal defect of the thumb. So the Fouché flap is the kite flap, as he described it initially, shaped like this, taking the skin that can be spared and safely full thickness skin grafted from the dorsum of the index finger to repair a defect of the thumb. And it's a really interesting flap. And I just want to talk about the pedicle of this, because this shows how knowledge of vascular anatomy and the anatomy of flaps is so important. And if anyone's a trainee and they're ever going to do this flap, read carefully about it before, and I'll tell you why. So there's one example of the flap where this dorsal skin there is transferred across as an island flap to repair the dorsum of the thumb. It can also be used to repair palmar defects of the thumb with sort of modest quality sensation from the radial nerve. Here's another example of a case. So when you raise this flap, there are things that to give it sensation, you need the branch of the radial nerve, and that is most ulnar and distinct from the vessels. And the veins which run with the artery are very small. So you want a big subcutaneous vein. So in raising this flap, what you do first is you make an incision down the back of the hand here, away from the skin island, down to over the anatomical snuff box, and you reflect the skin back, superficial to the dorsal veins of the hand. And you find a really good superficial dorsal vein. And then a bit wider out on either side, you dissect a bit deeper. And I'll just go on to the next diagram. So this is the cross-sectional diagram showing this is the index finger metacarpal and the thumb metacarpal with the first dorsal interosseous muscle in between. This is the skin here, and this is the subcutaneous fat. So when you raise this flap, you get this, you reflect the skin like this, and you find a really nice subcutaneous vein, and you trace it all the way back. So you trace it from here down to there to drain the flap. And then you dissect deeper like this and like this, and you just blindly make incisions through the fascia on the surface of the first dorsal interosseous muscle, quite wide apart, as wide as you can. So if you imagine on the back of the hand, these incisions to get the arterial pedicle are sort of going like this and like this. And you're taking a wide strip of fat and fascia with the artery and the tiny veins that go with it, the first dorsal metacarpal artery. So in terms of the principles of flap design and elevation, this is a classic flap where you really need to know the anatomy before you raise it. And you need to think about what you're trying to do, because unless you have fantastic magnification and fantastic view, you'll never see this artery which supplies it, because it's a small artery that's down on the surface of the fascia over the first dorsal interosseous muscle. So the way to preserve it is to cut en bloc. Once you've isolated a nice superficial vein, you cut en bloc down to there. So you're basically ending up with a pedicle of tissue, which is like this. With the nerve, the vein, and the artery. The vein you've exposed and maybe dissected separately. The nerve, you need to look for more ulnar at the base of the flap to make sure you've got it in it. And the artery you blindly preserve by preserving with your adipofascial pedicle the fascia over the first dorsal interosseous. And the key in terms of the anatomical landmarks is to make sure that this incision is right at the edge of the second metacarpal. So I think that's just, I've focused on that particular flap because it's, in my experience, 100% reliable flap that I've seen people occasionally raise and it just not work at all. And that happens every now and then around the body where people raise flaps without really knowing the anatomy well enough. So one thing I would say about raising named vessel flaps is never be afraid to read really carefully about them beforehand from the descriptions about how to raise them, and try and apply that to what you're actually doing. The Fouché flap is a really, really reliable flap for coverage of defects of the thumb. Just a few more questions on the Q&A. Jose Cabral, yes, I'd be very happy to get you a PDF of the webinar. I can put that on for BEFIRST. I'm very happy to do that. So good question from Daniel Bolan about dog ears. It's really interesting, Daniel, how Daniel's asking about when to trim dog ears. It's amazing how seldom dog ears actually end up having to be trimmed from transposition flaps for trauma. That I would have thought of the cases that I've done that every patient would come back wanting it trimmed. And it's probably only about 10 to 20% of the patients who end up coming back wanting them trimmed. The short answer to your question, Daniel, is probably if the patient's willing to accept it, leave it for about a year afterwards until all the scars have settled. Or if you're taking the patient back for a separate functional procedure, which is common for the hand, or if it's the lower limb with a fascicutaneous flap in the lower limb, try and do it at the same time of that. But my advice would be leave everything for a year. If you can, always consent the patient before about the dog ear so that it's not a surprise for them. Or if you do a flap that leaves a dog ear, tell them about it when the dressing's still on so that they're ready when they see it afterwards. And then people understand it. A very good question from Meheret Demisi about venous flaps. Yes, when I was training, we did some free venous flaps for coverage of defects on the fingers. Short answer to your question, Meheret, is I have no faith in venous-only flaps, and I stopped doing them a long time ago. But arterialized venous flaps do work really quite well. And in the United Kingdom, Mr. Pickford, who's a superb hand surgeon from East Grinstead, I think, has written a very good paper, I saw him give a presentation about it. I suspect he's written a paper about arterialized venous flaps for coverage of defects in the finger. I would recommend you to try and get his material. Mr. Mark Pickford, his name is. I used them for a while, about 25 years ago, and I found that most of the defects that I used arterialized venous flaps for, I could actually solve with a different non-free solution, and I stopped using them. Very good question from Noor Ain about use of medicinal leeches. I hate using leeches. So if I have venous congestion in a flap, as soon as I recognize it, I try and do something totally different, like even putting the flap back where it started and trying a different option. Leeches work in a minority of cases for flaps, but I think they work most successfully just for tiding things over for a few days. But the number of times that I've seen leeches help for flaps that truly I think made a difference is small. So I would tend to recommend, if you have genuine venous congestion, which you cannot relieve by other means, my own feeling, I'm sorry, I know that this will not be the same as many of the people in this webinar, listening in this webinar, but my own feeling is I've seen a lot of harm caused by leeches for flaps and not so much good caused by them. I think there are separate indications for using medical leeches in small replants, which can work well, and very occasionally in flaps, but you have to be very clear what you're trying to achieve with the leeches and not just allow it to be something where it just goes on and on and on for days and days and days, and the underlying problem is not addressed. Dimitri Shelemko asks a good question, which is, do you really need to take the nerve? And no, if it's for a dorsal defect of the thumb, you don't need to take the nerve, Dimitri. That's really for the palmar defect. But the nerve is very close. But it's a good question because the nerve can be the tightest structure. If you're struggling to get a Fouché flap to reach in coverage of the dorsum of the thumb for the nail complex, then it's not a bad thing to cut the nerve if your flap isn't quite long enough, because it doesn't matter on the dorsum. So thanks for that question, Dimitri. Tino Sebastian, question about maximum length to width ratio in hand surgery. I think that's a great question, Timo, and it specifically it addresses it's something I just cannot answer. But the point about length to breadth ratio is that it is determined by the quality of the perforating vessels going into the base of the flap, and whether you have a longitudinal, consistent vessel going along the length of the flap. So wherever you have a good quality perforator in the base of a flap, you can have a length to breadth ratio of getting near 3:1. If you have a specific named vessel in the length of a flap going along a flap, then length to breadth ratio just doesn't matter because the vessel supplies the whole length of the flap. So that's where you have to ally these fundamental principles with a knowledge of the vascular anatomy. Very good question from anonymous attendee about dimensions of fascial flap. Simple answer to that is, if you're taking a fascial flap, always take it bigger than you think it needs to be, because for some, although they don't have any muscles in them, for some reasons, when you lift a fascial flap, it always ends up smaller than you think it's going to be. And most fascial flaps, when you're actually planning the flap, correspond to the vascular territory of the skin flap. So generally speaking, you can think that it will be like, if it's a radial forearm fascial flap, then it's approximately the vascular territory of the skin flap. But when you take it, it always seems smaller when you move it to the defect than it was in the donor site. And fascial flaps are more inconsistent in terms of healing than good quality skin or muscle flaps, in my experience. So you want to be generous with the amount of fascial tissue that you have for a fascial flap. I hope that answers that question. Oh, I'm sorry. My sincere apologies to anonymous attendee who's asked about the Snow-Littler procedure for cleft hands. I don't know that one well enough to answer your question. I'm sorry. I'm kind of, I did a load of hand surgery, but I was mainly a trauma hand surgeon. Very good question from Ehab Basturios. Says, do you tunnel the Fouché flap? And answer to that is yes, with care. If you have a patient who's older, with loose skin, who's not obese, and whose hand is not very swollen, then yes, tunnel it. If you have a younger patient with a tight hand and a swollen hand, definitely don't hesitate to open the skin over the length of the pedicle and put a little skin graft over the top of it. Or do that thing where you zigzag the incision over the top of it and stitch the tips together and put in some little skin grafts. Reverse sural flap, that's a good question. Can the nerve be spared? I don't think so, because in a reverse sural flap, part of the blood supply is actually the vasa nervorum, which run with the nerve, and you actually rely on it's actually very similar to that Fouché flap. This diagram, the person who's asking about the reverse sural flap, it's very similar to this diagram. If you're doing a reverse sural flap, you're basically taking a composite of fascia, fat, veins, little arteries, and a nerve. So you just need to keep it all together. I hope that answers the question. That's a good question, actually, because in these flaps with adipofascial tissue, it's best to think of the safest way of raising them as just taking a composite piece of tissue like that, rather than unduly dissecting out the individual structures. Although for the Fouché flap, I found the nicest thing to make it thin was to dissect the vein out separately, because it's more superficial, and then take a composite like this. I hope those answers make some sort of sense to the audience. So another thing that I think is really important, and this is the hand is a good example, is to get used to thinking of the true dimensions of the defect. So when we look at this thumb tip amputation, what we see, what our eye tells us that the defect is that, but it's not, it's that. So one thing I got used to thinking about if I was repairing amputations, and this corresponds to what I was saying before about the contour and the curve of structures of the body, is that the length that your flap needs to advance to properly repair this is not that, which would be just that length up the finger, but it's that, which is actually about that length. So that's a really, really important thing about coverage of palmar defects, is remember that to get a nice result, you're actually looking at reconstructing that defect rather than this. So this is using the hand as an example, but there are many other parts of the body that are like this, and it's particularly true on the face, which is a convex structure, that you look at it in 2 dimensions and you see a certain size of defect, but if it's over the convex part of the cheek, the defect you've got is actually bigger because of this effect. So I hope people appreciate and understand that. So next important thing about this specifically relates to the hand, and is something that I think is really a nice thing to know clearly about reconstructive plastic surgery, is the drainage of palmar flaps on the hand. And this is a diagram of a digital artery, a digital nerve, and the veins which drain the common flaps on the palmar side of the hand. So this doesn't apply to dorsal hand flaps, and it doesn't apply to so many other parts of the body. But these veni vasorum and veni nervorum, particularly the veni vasorum, these little tiny veins, that's what these structures are what drain a lot of the palmar skin flaps of the hand that we use. And for this reason, whenever you're raising hand flaps, one of the palmar hand flaps, one of the key things to think of is never skeletonize your vessel, your artery. And the person who first recognized this, which is a phenomenal thing to do, was almost 70 years ago, the American surgeon Littler, who described this heterodigital island flap for coverage of defects of the thumb, the sensate flap. So what he did was he raised flaps which were based on the digital artery, but preserving the tiny veins that run around it. So I think I've made that clear enough. So again, to get back to the principle of coverage of defects at the end of the thumb, using this Moberg flap to cover the end of a digit, you have to bear in mind that it needs to advance that distance rather than that distance because of the thickness of the flap, if nothing else. You know, there is volume in this tissue which is going to go over the end of the thumb. And this flap is a flap which is raised with no large venous drainage. The venous drainage is based on the veni vasorum around the digital arteries, so you must preserve the digital arteries. And for those of you who aren't familiar, what essentially happens with a Moberg flap to repair the thumb is you have sorry, I'll just change the color of this, is you lift this skin up completely off the thumb as an island with the pedicle of the veins and the arteries in the base of it, leaving those attached, obviously. And then it advances up the thumb. Key things are about it: the incisions have to be mid-lateral. Usually the proximal incision is at the most distal crease at the base of the thumb, and you have to completely mobilize it off. So you have to be very careful not to skeletonize these digital bundles at the base, because that is where the venous drainage of this flap is going. And this flap only works on the thumb because if you do this on a finger, the dorsal blood supply of the finger is poor. and you're at risk of getting a necrosis of the nail complex. Whereas the dorsal blood supply of the thumb is much better. So you can do this with these two pedicles on the thumb, but you can't do it on the finger. So again, just to emphasize, a lot of palmar flaps don't have a significant vein draining them. Venous drainage depends on this complex of vessels around the artery. Another modification of the Moberg flap is Mr. Elliott's. He's a great hand surgeon from Chelmsford in England and UK who's innovated lots of beautiful techniques for hands. The standard Moberg technique is primary defect is closed with the flap and the secondary defect is then covered with a skin graft. So this is a pure advancement flap. But Mr. Elliott and I think colleague Mr. Moyman produced this modification, which is a V to Y closure using this loose skin here. To be truthful, I've always just put the skin graft in at the bottom, but this is another option. It just shows the different principles, but the principle here is that you're using the loose skin at the base of the thumb to allow the flap to advance distally. So it's the same principle as rotation flap. So this is an example of the whole category of V to Y advancement flaps, which use distant loose skin to allow advancement. So a V to Y advancement flap for the fingertip that's in all the textbooks is the Atassoy-Kleinert flap. And I just have to be prejudiced here and tell you that I never ever used this flap because I saw so many bad results with it from other people. And there are a couple of reasons that I never used it. One is I was taught about fingertip surgery by a very, very good hand surgeon when I was a trainee, a guy called Donald Samet. And he felt that this flap was inferior because it left scars on the pulp of the finger, unnecessary scars on the pulp of the finger, particularly on the lateral pulp where you bear it and also where you touch the finger. Secondly, it tended to give a tight scar over the DIP joint unnecessarily. And thirdly, it's based on absolutely tiny vessels. So my advice would be, don't use that flap. So I'm allowed that's my bit of prejudice for today. After Littler, another great innovation in hand flaps was the Venkatswamy flap from Dr. Venkatswamy from India about 1970, which is this island flap where you take a V to Y advancement with the digital nerve and the digital artery as an island flap and use this to cover defects of the fingertip. And that principle is the basis of a lot of excellent surgery for coverage of fingertips. So if you're thinking of advancement flaps for fingertips, I would use this principle where the advancement flaps are based on digital nerve and artery rather than the Atassoy flap. And that, to me, is the safest way to get consistently good results. This demands a significant level of surgical care and a bit of skill. Other little things, technical tips to think about, this is now pure hand surgery rather than principles, is if you're covering defects of the fingertip and you've got a decent length of nail complex, never hesitate to trim the bone back a bit, to cheat a bit. Because remember, the flap has got to advance that much, not that much. So if you shorten it, it makes a big difference to how far your flap's going to go. But obviously you can't cheat it too much and over shorten your nail complex. Otherwise you get a very unnecessary hooked nail. But up to a reasonable point where maybe you're retaining about 2/3 of the length of the nail complex, feel free to shorten the bone a bit. in the interest of getting a flap that advances over the finger end to work. So part of the thing about local flap surgery is also knowing the ways that you can cheat to help your case to work. And I'll talk a bit more about one or two other things that are doing that. But Dr. Venkatswamy did a great thing when he introduced this, but I use a slight variation of that, which is described by another great hand surgeon from Britain called David Evans, which is this step advancement, V to Y advancement flap. And the problem with the Venkatswamy one is you get a contracture potentially over the DIP joint, whereas if you zigzag that edge of it like that, then you don't get the same contraction. And a useful thing to think about if you use the Evans method is that this distance here to the first zigzag has to be the same approximately as that distance there. So that when you put that on, and this is it's not a cheat, but this is a trick for a lot of flaps. If you can find a way of locking the flap in position using the sutures or using the anatomy, and in this case, it's using the anatomy. If you imagine this steps up, this ratchet of the flap steps up to sit on there, and that holds the flap forward and takes the weight off the stitches. So that bit of the flap sits over the end of the finger. So much simpler flap. Go back to basic principles of flap. A very simple flap that I like for coverage of slightly easier defects of the fingertip in people who want to get back to work quickly is this modified Houston flap, where the flap is just dead simple like that. And it's a rotation advancement flap. And I much prefer this, and I've used it over many years after Donald Samet taught me to do it, rather than the Atasoy flap. And it's for simple defects of the fingertip, much better. The Evans and the Venkatswamy are for slightly more oblique defects that are a bit trickier. But especially if you have a completely straight across or slightly oblique dorsal defect like this, modified Houston flap works really well. The key things about this are you have to elevate this flap completely off the bone and the flexor tendon. But the most important thing is you keep the digital nerve and artery on this side with the flap. You don't leave them behind and lift the flap off these. And this is the crucial thing, is that it gives the flap sensation. Other things to think about here are the back cut makes a big difference to how this flap moves forward. So you can see how it's planned like this, but it'd be as well just to put into the plan a back cut like that. And you elevate it all the way across. So this whole flap is undermined, but you don't go beyond where the little vessels come into the base of it from the digital artery here. And you keep this digital artery with the flap. And then usually it's a skin graft on the secondary defect. One more thing that I want to use this to illustrate is using sutures to hold flaps in place. So one thing that I kind of started doing as a discipline with advancement flaps in the fingers is not putting the first stitch at the tip of the flap. You know how if you do an advancement flap, there's a tendency to want to put it over the bone at the end of the finger. I always put the first stitch here, and I put it like that to see if the flap will then sit in the defect where you want it with almost no stitches. And then the stitches that go around the distal part, securing that to the nail bed. So the stitches that would be going onto the nail bed are just really there just to help it sit. So if when you do advancement flaps, you can focus on using these stitches to get it in the right place, then and it does that, then your flap is a good flap. I'm sorry, I've misspelled Houston there. That should be an E. Sorry. Terrible. Houston. So I'll talk a bit more about suturing for flaps, but use your stitches to push the flap forward, not at the tip, but further back on the flap. Because if you have to put tight stitches at the end of the flap, that is the classic way that you get flap necrosis. We'll just stop for a couple more questions. Flap that's best to cover tendons. Short answer to that is generally fascia is believed to be better than muscle. If you can have flaps with fat and fascia in them for coverage of tendon, that's generally believed to be the case. But muscle flaps still, you know, there are some situations where muscle flaps still work beautifully. Good question from Tino Sebastian. I do cut the Edwards anastomosis in the Evans Van Swami flap in the majority of cases. I went through a phase of trying to preserve it, but almost every case I ended up at the end cutting it to get enough because it's a little bit like the Atasoy flap. It actually, because it's very small and it hasn't got much range, it restricts the amount that you can move the flap forward. So I almost always cut it. I think we're talking about the same thing. I think these are the transverse vessels in the pulp, I think is what Tino means. But it's a nice question, Tino. Thank you. Visor flap. Mahmoud Gouda. Mahmoud's asking about the visor flap. Could you put another thing on about this, Mahmoud, to explain? Do you mean for the face? Or is this an advancement flap on the finger that's called a visor flap? I'm sorry, Mahmoud, I'm not familiar with that. So, as one of the questioners asking about the Tranquilli Liali flap, I'm really sorry. I think that's useful for the delegates, but I don't know that one. Please excuse my ignorance. There are lots of great flaps for fingertips. I'm just talking about the ones that I did, but I would encourage you, when I was training and working a lot, I read a load of stuff, and always be on the lookout for good flaps. And thank you for the nice comments from Sanjay Majumber there. Thank you. Mizati Chikalipo, thanks for the question, Malapi, asking about toe transfers. Very rarely toe transfers are indicated for tip injuries of the finger. They are mainly indicated for large losses of the pulp of the thumb, Mizati. So good question, but mainly the indication for the toe transfers is large losses of pulp of the thumb. Nice question for another anonymous attendee about fixing finger flaps to cover tip with K-wires. I think that's a very good way to do it. Laterally, I didn't do that. I relied on these stitches there to hold the flap forward and thinking about that as my emphasis. But the technique where you skewer the flap with a very thin K-wire is a really nice technique. So I think the person who's asked that question, good question, thank you. Defect at the base of the digit on the palmar aspect, a difficult defect. That's a good question from Abdel Al-Beiti. The problem with that is usually if you have a defect at the base of the finger, they're usually quite complex injuries. Abdel's asked a good question there. He's asked about coverage of defects at the base of the finger. So if I draw a defect here, if it's not too bad a defect, Abdel, what I've often done actually is just made incisions like this as if you're exploring the finger, you know. So if you've got a defect there, plan your exploratory incisions going onto the palm, and then just use those as synchronous rotation advancement flaps. So that's a good thing that I've done for fairly simple defects at the base of the finger. There are descriptions that you can pass the quaba flap through from the dorsum to the palmar aspect. I have to say I've not done that since I was a trainee because it was tricky, and I didn't particularly like it for that indication. And question from Kathit Gamiri about the tip of the Houston flap. You can just leave the tip of the Houston flap. I usually just, I usually do actually suture it down, but if you're in doubt, leave it open and let it heal. It's better to leave the tip of a flap on the finger open to let it heal rather than necrose it with tight stitches. So thanks, Kathit, for that question. Stanley Akubuko asking about exposed bone for tick. I definitely trim exposed bone for fingertip injuries, as I said, to help cheat. But my own feeling is you don't want to trim it more than 2/3 of the visible bone nail complex. Otherwise, you get more and more risk of a really nasty hook nail deformity. If you trim it down to about 2/3 length of the nail complex, you do get some curvature of the nail, but it's not bad and the patients didn't object to it. So I don't hesitate to trim the bone back a bit, but that's my criterion, about 2/3 of the length of the nail complex. Good question from Chijuke Okonkwo about timing of division of cross-finger flaps. Our basis for deciding on cross-finger flaps, Chijuke, is if the patient's hand is functioning well with the flap present, then, you know, if they can flex and extend their fingers a little bit and do a little bit of physiotherapy, then we usually leave it about 3 weeks. If you have to do a cross-finger flap for the fingertip, then I think you're right. I think try and divide it early by putting, I'll show you, I'll explain when we get to the slide about a cross-finger flap. So next one, just briefly to cover cross-finger flap for palmar aspect. That's the donor defect. Really, really important in cross-finger flaps is good care for the donor defect. So always use a nice full thickness skin graft and be careful to get it to take well. So something that, one very small trick that I would pass on to you is for a full thickness skin graft, I like tie over dressings. So if you can imagine for a tie over dressing for a full thickness skin graft, you put stitches all around like this and then you tie them over. You can also, if this is the side of the flap here, you can put a stitch down to the deep tissues there so that your graft snugs down. And that helps to get really, really good graft take, because otherwise the graft tends to lift away from the bed there. So think of ways of getting really good take with a full thickness. So I'm sorry, I can't remember the name, but one of the delegates asked a good question about when do you divide cross-finger flaps, and this is one to try and divide a bit earlier because it's for a defect of the pulp of the finger, and it's this is where you would try and divide a cross-finger flap after about 10 days. And what you'd do is you'd maybe tourniquet the finger first to make sure the flap is viable, and you'd be careful about that after about 10 days. But if you have a good inset, it's likely to work well. Other things I was always taught, and I've never strayed from this, never suture closed the defect of a cross-finger flap after division. Always just leave it to heal itself, because if you do, you might cause tension or infection that could compromise a really nice flap. And the donor defect, always just, if there's a raw bit there, always just leave that. So just leave this bit here to heal. Don't stitch it closed. So that's how to divide a cross finger flap early. If you have it on the fingertip, do it early. The problem with the cross finger flap on the fingertip is it's no sensation and it's the wrong type of skin. So use them sparingly for fingertips when you've no other alternative. Always try and find a better alternative to a cross finger flap for a fingertip. But obviously, if you have to do it, then do it. But it's the wrong kind of skin. It's wobbly skin and it doesn't have good feeling. Here's a little, this shows how you can use things that aren't in the books. Here's a little variant of a cross finger flap. This patient had a really bad infection of the thumb that got cleared up with exposed bone at the tip. And we were scared to do a Moberg flap because of the severity of the infection. We thought there might, you can see how the skin was damaged by the infection. So we designed this little islanded flap based on the ulnar digital artery and its little veins from the index finger. And we left it attached for 2 weeks. And we put a little tiny skin graft around the pedicle. And we're careful to make sure there was no tension on that. See the donor site closed. And that was it in the long term. And it's the right kind of skin, doesn't have sensation, but it picks up good sensation because it's small. So that's one, you wouldn't do this flap very often, but for a tricky problem with the tip of the thumb, it's a possibility. But again, it's just an example of how you can use the different principles of the flaps in the hand and in the body generally. So finally, moving on to how to choose flap using large flaps elsewhere in the body. So for the hand, again, using the example of the hand, I'm just going to talk about some of the principles of the radial forearm reverse flap. So key things to think about if you're doing a reverse radial forearm flap. This flap has been passed through a tunnel to cover this difficult defect to the dorsum of the hand. So always make sure that you design the flap proximally enough so you have a good reach to reach the hand. Make sure that your pedicle is not tight and not kinked. The only problems I've seen with radial forearm flaps to the dorsum of the hand have been a tight pedicle. So make absolutely sure that you design the flap so that you have laxity here where your pedicle comes through from the palmar aspect. And if you're in doubt, just release the skin here and put on a skin graft over it, over the pedicle, rather than tunneling it through. It's just an example of free flaps. I think I'll just go through this quite quickly because this has been quite long. So using flaps from elsewhere, nice way to cover difficult defects of the dorsal hand is a free lateral arm flap. This is a boy whose hand was trapped in a hot metal press for 10 minutes. A hot plastic press for 10 minutes. Important principle about the hand. People were asking about fasciocutaneous flaps, and that the lateral arm flap does remain a very good option for the dorsum of the hand because it has fascia and you can put the tendon grafts through. And this boy actually had needed all his tendons reconstructed. Our finding has been that and I think this is orthodox practice, is it's always better to do your tendon reconstructions secondarily after a few months when you have full passive range of movement, rather than putting in tendon grafts straight away in really bad injuries. So if in doubt, do your tendon reconstruction secondarily when the bed has settled. And I think in that situation, if you can put in fascia and good quality skin, it's probably superior to muscle. In answer to some of the questions, I'm just going to go through this very quickly because this is a complicated case of a girl with a really bad burn contracture and an unstable scar here where there was no local flap that we could use. So in her case, this is the defect after release of the contracture. In her case, this is just to show the principles of flaps. We used a combination of an adipofascial flap like that and a skin flap because we needed two flaps, one for the dorsum of the hand here. One for the dorsum and one for the first web space, having released the contracture. So it's a classic, really bad dorsal hand contracture. And the question that one of you asked about adipofascial flaps and how big to make them, you can see here, I've made a big adipofascial flap that's kind of like that. That's what I've raised on this young lady's forearm. But the flap, when you actually take it out, ends up being quite small. So with adipofascial flaps, always plan them a little bit bigger than you think, or significantly bigger than you think. But it's a nice donor site, this, because she had some loose skin in the forearm and that closed up well. So she's had a free flap, this lady, to free chimeric flap, they would call it, with adipofascial tissue across the dorsum of the hand here and skin flap here. And there you see the clamps for anastomosing to the radial vessels. I'm sorry, I'll just go through this very quickly because it doesn't add so much to the teaching component of this. But we covered this with Integra because we were going to put Integra on the unstable scar that she had there. And that's her result. You can see how, I talked about local flaps in the dorsum of the hand, and using the dorsum of the MCPs for a donor site for rotation flaps isn't so great because you do need flexion there. So always think of that. So groin flap remains hugely important so this is another similar patient to that who's had this groin flap to the back of his hand for a burn contracture. And I just want to talk a bit about groin flaps. Here's another case, patient having a groin flap. So obviously the groin flap has, in sort of high income countries, it's developed somewhat bad press in terms of not being used very much. And the key issue is that it keeps people in hospital for several weeks. And the second issue is that the patient's hand gets more edematous than would otherwise be the case with a free flap. But it still remains a hugely important option. Things to think about with the groin flap are, before you raise it, learn about the various planes that you need to be in as you dissect across laterally, and about how, as you dissect laterally, you go more superficial and you get the distal part of the flap there thin. And if you're doing it for a really bad burn contracture and you want a really big, really thin flap, consider doing a delay procedure where you cut out this lateral random part of the flap to here, to the anterior superior iliac spine, and undermine it, and then put it back down and let that acquire a good blood supply. Obviously, you can't do that for trauma cases, but if you've got a case where you need a really big flap for a really difficult hand burn contracture, that's something I would suggest thinking about. Do the delay procedure to give yourself a bigger bit, or make it, like round like that at the end even, so you get a bigger flap. So that's something to think about. But the only thing I find difficult about the groin flap is just the different planes going across the surface of the sartorius muscle here and then changing to become more superficial. So anyone who's unfamiliar doing a groin flap, read about the planes that you need to be dissecting and going across there. Where possible, tube the flap, but if in doubt, just either dress the bridge to the groin flap, or even if you're worried, put a very thin skin graft on it if you're worried that you can't tube the pedicle. If you can get a really, really good quality inset onto good quality skin, it means that the flap has to be attached for less of a length of time. And I always have the discipline that I clamp it with a soft bowel clamp before I divide it, to just make absolutely sure, because your patient's gone through a decent length of time to get to this stage of having the flap. So you want to make absolutely sure it works all right. If you can, if there's any way at all to get therapists to work on moving the fingers and the thumb, isn't always possible. Often you've got K-wires in, but if there's any way of getting therapists to move the fingers and the thumb and get the patient moving, then do so if you have the right kind of patient. Groin flap is still worth considering in many, many situations, because here's a case from Ghana, really difficult case of a delayed bad hand, but you can see how in this situation you have to leave the groin flap attached for longer because it has a fairly poor inset, doesn't have a very good skin inset, so you're unsure of the quality of the inset. When you divide it, don't feel you have to do anything fancy with the edge of it. Better just to leave it and let things settle down a bit. You don't need to close it really neatly when you divide it. There you can see this flap, which has just been left to sit like that after it's been divided. A bit later on, it's just healing in really nicely with no stitches put in there. So where the flap's been attached, if you've got a really clean wound, then by all means stitch it in nicely, but don't overdo it there if you don't have to. Other flaps that remain hugely useful are random abdominal pedicled flaps for smaller defects. But if you have a Doppler machine and you can identify a perforator to base this flap on, that would be better. So we never really had to use these flaps working here, but if you have a perforator in the base of this flap, then it's going to be easier. Reflects back to one of the delegates' questions about how long can you make a flap. If you know there's a perforator there, then you can make this flap longer and narrower. So that's that after it healed. Cross-leg flaps remain hugely important for coverage of defects in many parts of the world. Key things to think about are you want to raise the flap, make the most of it, raise it all the way around the back of the calf to the mid-lateral line on the opposite side. But when you raise the flap, when you come round to the front, so you're taking the flap from the posterior aspect of the calf all the way around there. But when we come round to the front, make sure you preserve these perforating vessels at the posterior edge of the tibia. And that way you get optimum blood supply. So the perforators of the posterior tibial artery come out just 2 centimeters posterior. So that's posterior to the posterior edge of the tibia. So that is a good landmark for where your flap should be. So there's an example of a huge cross-finger flap, done cross-leg flap, sorry, done exactly like that. Other examples could be a smaller flap. Also, designing the flap as a distally based flap, as this surgeon has done, is a very, very good option, where you make a flap design like this. And for smaller defects, as this surgeon has done, that allows more flexibility, more mobility. So the key to the optimum vascularity is these perforators in the base of the flap. So that's a fundamental theme of this talk, really, is think about getting perforators in the base of your flaps or named vessels going into your flaps. So I just want to talk briefly about fasciocutaneous flaps in the lower limb. Hugely important, very useful, particularly if you don't have facilities for doing free flaps. Then the distally based variety of fasciocutaneous flaps, usually based over the posterior tibial perforators here, where I'm just drawing, are very important and very useful. You don't always have to take the base of the flap as big as this. It is one of these flaps where the distally based fascicutaneous flaps where you can have a flap that's like, sorry, not drawing that quite right. It's sort of like that shape, as I said at the start, if you have a good perforator in the base of it. So like that. So that's going around the back of the leg. So you could take that flap even narrower if that's around the back of the leg. Proximally based fascicutaneous flaps are very vulnerable to this matter, which I was talking about the finger, of moving the flap round a cylindrical structure. So always make sure you have enough length on a proximally based fascicutaneous flap. So you can see there, that's actually looking at this proximally based fascicutaneous flap. That's about the minimum that I would go beyond the defect to get the flap to sit in, to allow for post-operative swelling. So if in doubt, mark your flap a bit longer. Doesn't really make any difference to the donor defect for the patient. It just makes it safer, because when you move it round and once it swells, you need the length on the flap. Again, remember the leg is a cylinder, and the distance that matters is this outer distance, which is influenced by the thickness of your flap. And when it swells, your flap effectively shortens. Very, very simple way. This goes back to what I was talking about, shape of defects. Very, very simple way of covering defects on the distal lower limb. If the defect is this shape, which you do see particularly in older people with burst injuries, is you make sure that the incisions for exposure of the fracture are like this. And then you can design interdigitating or reciprocating simple rotation advancement flaps with little skin grafts on the secondary defect. And for the questioner who asked about defects at the base of the finger, that's what I was trying to explain. If you have a defect at the base of a finger, then you make an incision in the midlateral line distally and down onto the palm proximally, and you can then, if necessary, back cut a bit like that. Back cut is a Brunner incision on the finger, and then you get incredibly simple flaps to close defects like this. The difficult thing in these cases is sometimes, if it's the distal leg, is getting this flap big enough. You don't want to be making a small flap that then exposes your fracture in a different place. So you just have to make sure you get far enough away. And to do that, you have to back cut a fair bit. I hope everyone understands that. Finally, just a few points about some of the common facial flaps. Very, very important in facial flaps, whenever you can, is to stick to the aesthetic lines and avoid unnecessarily making flaps in the middle of the key aesthetic areas. If you're working on the forehead, to make them flaps go in the creases where you can. Obviously, in the very important matter of nasal reconstruction, we violate that principle by taking flaps like that. But if possible, don't unnecessarily make flaps in the middle of the cheeks, and try and stick to the aesthetic lines at the margins. Next thing that I think is really important principle of eyelid reconstruction is try to use flaps that help to keep the eyelids in a good position. So for example, this is a muscocutaneous Trippier flap. So one of the delegates asked about how long flaps can be. So this is an incredibly long, fairly narrow flap. And it works because it's a muscocutaneous flap with, I can't remember the name of the branch, but there's a branch of the ophthalmic vessel, I think, that runs in the muscles. So you take this flap with the orbicularis muscle. It's a modified Trippier flap, and this would be for a defect of the lower eyelid. So when this flap is sutured in place, it pulls upwards like that. So it helps to pull the eyelid into a better position. So that's a really useful principle to think about if you're designing flaps for important areas, is to make sure that you, where possible, the direction of pull, if it's for a functionally important area, is favorable. So the next example of that is the McGregor flap from Canisburn many years ago, also for reconstruction of eyelid defects. And you see how what McGregor did was he made sure that he drew this flap to go upwards like that, and that when you do the Z-plasty of this rotation flap afterwards, it is an upwards direction of pull. So it's pulling the eyelid up rather than down. Finally, if you ever do a big mustardy cheek rotation flap, you make your incision start by going up like that, not straight across. And then once you've undermined and advanced the rotation flap, if you possibly can, you hitch the deep surface of the flap onto something strong over the mastoid, because the weight of the flap pulls it down. So you try and do two things. You make sure, as McGregor did with his cheek rotation flap, that the start of the flap goes upwards, so that the direction of pull of the scar is upwards. But particularly in the mustardy cheek rotation flap, you hitch the flap to a strong, deep structure, hopefully avoiding damaging the lower eyelid branches of the facial nerve. So that's me just about finished. There is one more thing I just want to draw for you, actually, but this is just a summary to say application of the principles of analysis of the defect. So the shape of the defect matters a lot. The volume of the defect matters a lot. One or two people asked me about that. The next talk, if people can bear to hear my voice anymore, will be in a month. And I'll talk more about choosing different flaps for defects and how you can think about that. And flap planning takes many forms, and those are just some of my ideas from my career about that. Just the one final thing I was going to say, I forgot to clarify this, but if you have a defect and you have a transposition flap that you're putting into it, having transposed, so imagine that the flap's going in like this. Let's say this is on the lower limb. I always now, if the flap is even, if I'm even slightly concerned about it, I always stitch it in oblique with stitches that go obliquely like this, so that every single stitch is pulling the flap towards the end of the defect. So it's what I was saying to a lesser extent about the Houston flap on the finger, that the flap, the stitches hold it forward. But one thing, the reason I mention this is one thing to avoid is sit your flap into the defect, put the stitches in here, and then just stitch straight across like that. Because what happens is because the flap's elastic, the stitches at the end hold it, but it then gets tight and it's wanting to go back like this. So it became like a minor trivial religion to me when doing transposition flaps, or even stitching in sometimes free flaps or muscle flaps, that rather than focusing on the stitches at the end and then stitching the flap in, I would focus on the stitches further back and try and put them in a way that pushes the flap up. So that, I don't know what degree of difference that made, but a long time ago, a surgeon from Romania whom I worked for called Stefan Lucian said to me, tension control is one of the keys to plastic surgery. And this is a kind of tension control. If you stitch the flap in with the stitches at the end first, and then just stitch across like that, you're potentially using these stitches to increase the tension on the end of the flap. Whereas if you try, if you say you've already stitched in the tip of the flap, if you try and stitch obliquely like that to pull it in, or even just as you're putting the flap in, you put in stitches like that way, you get my point. I'm laboring it. Anyway, thank you all for your attention. I'll just go on to the Q&A. A question from anonymous attendee: should we sacrifice PIP joint coverage of the index finger if we need a long Fouché flap? You don't need to do that. You mustn't go beyond the first bit of loose skin of the dorsum of the index finger with a Fouché flap, because if you have a thumb pulp defect that you're struggling to cover, you're much better, I feel, just to shorten the bone a little bit and get your flap to sit in than to take skin from the dorsum of the index. So personally, my answer to that be no. Never violate the good skin, that loose skin that you see over the dorsum of the PIP joints. Tarek and Mari, so that's a really good question about cross-leg flaps. So my namesake in Manchester, Stuart Watson, taught me how to do cross-leg flaps when I was a registrar. And we immobilized the patients using maybe 2/3 of the length of a broomstick with lots of padded bandages and plaster of Paris. So you don't need an X-fix to immobilize for a cross-leg flap. Basically what you do, I'm trying to remember now how we did it, but you basically put on a couple of back slabs, and then you use really good quality sticky tape to stick the broomstick to the back slabs, and then you put some plaster of Paris on top of that. Tripier flap, if you've got a significant conjunctival defect, yes, definitely would use a conjunctival or mucosal graft. The only thing is sometimes you can just, if it's for a smallish defect, sometimes you can just mobilize the conjunctiva out from the lower fornix. So if it's, you know how sometimes if you've got a defect to the lower lid, there's more skin defect than conjunctival defect. And if that's the case, you can mobilize the conjunctiva a little bit. But if you're in doubt, I would put on a graft as well, because it's a shame if you've got a nice skin flap for the conjunctival surface then to shrink your nice skin flap. Bright, from Malawi, thanks for the question, Bright. Yeah, that is the issue with groin flaps, basically. The long-term issue with groin flaps is the greater risk of stiffness of the hand. And, you know, the two reasons that they're not so popular in high-income countries are the length of hospital stay and the increased stiffness of the hand. So, as I said, definitely worth thinking about how you have a long enough tube or pedicle on the groin flap so that the patient under guidance can move their limb a little bit, and also to give access for the therapists to move the fingers a bit. Because that 3 weeks, you could understand how that 3 weeks of edema and immobilization can compromise a result. It's less of an issue in children because the children recover more from swelling, and I wouldn't necessarily terrify a child by forcing them to move. I think the last groin flap I did in a child in this country, done them in Africa, but last one I did in this country was for an electrical burn, and I don't think we tried to move that child's fingers at all. So I would say the exception, Bright, is for children that you don't need to worry so much, but for the adults, I would work quite hard on mobility.
Thank you.
So Meher Kostanen's asked a question. I'll see about getting that lecture, Meher Kostanen. Thank you very much for your question. He's asked about a question on neck dissection and incorporating flaps. Just give me a moment to write that. I'll just take a photograph of your question. Excuse me, Naveen, sorry.
No worry, no, that's all right. No, thank you. I was just going to say thank you very much. And yeah,
I don't know
I was just looking at your last diagram with the oblique sutures, and I think everyone talks about tension-free closure, and I don't think that as such exists unless it's a free flap, perhaps, maybe, which is just sitting there, but
I totally
it's
agree.
controlling tension, it's sharing the tension, and it's also sometimes you can put stitches in that end up undoing other stitches working in the opposite direction, and so you just have to. I think you're absolutely right. It's controlling the tension, as your colleague from, is it Romania? I think you mentioned.
Yeah. Yeah.
And then I was just going to say cross leg. Actually, I did a cross leg flap in Gaza a few years ago now, before all current troubles. We just bandaged the legs together, and a young sensible patient who walked on the good leg with crutches, and did absolutely fine. So and I think they, even if they pull on the pedicle, they feel it and it hurts, and they stop potentially because they're you're trying to pull the pedicle, the flap.
Yeah.
Not necessarily just pull the pedicle off the defect, you're also trying to pull the pedicle away from its the flap away from its pedicle. And quite, I think they get a bit of feedback from that. So I haven't bothered ever doing the BOP broomsticks and taping, but thank you very much. That was amazing. I really enjoyed that, and I'm sure but Bhavika and Siobhan and Tony can work out a head and neck lecture or webinar at some stage. I suspect I'm sure we can fit that in at some point, because it'll be brilliant. And I don't know, I was just gonna wind up. I do not have the details of future webinars, so if one of you guys wouldn't mind perhaps mentioning that, Siobhan, that would be great.
Yeah.
And then once we've done that, we can draw things to a close.
So
Yeah.
sorry.
The next webinar is on the 16th of March.
Great.
We'll be sending adverts out for that shortly.
Brilliant.
Make sure you're following us on Instagram and Twitter, because we post everything on there as well. And
also for those of you who can, please do come to Leeds as well, to the Overseas Day. I think that would be really good fun. It's not just for consultants. We're encouraging trainees, students, and we're also about to start a nurses and allied health professionals subcommittee as well, for Be First. We sort of missed a trick for a long time with that. So again, if you know good people that you think will want to get involved in this kind of work, please come along. Or I'm not entirely sure whether we'll be able to make it available online live. That can be difficult sometimes, but we'll see if we can record some of the talks and things and perhaps put them on the YouTube channel as well. Great. No, so thank you very much, and see you next time. I shall draw this webinar to a close, and thank you, Stuart, for a brilliant talk. Thanks for taking the time.
Thanks to all the audience for joining.